Today we'll be going over meningitis. Meningitis can be defined as an inflammation of the leptomeninges and the subarachnoid space. Meningitis is most commonly classified based on duration or cause. Based on the duration of the infection, it is divided into three groups: acute meningitis, lasting less than 5 days; subacute meningitis, lasting more than 5 days but less than 4 weeks; and chronic meningitis, lasting 4 weeks or more. Based on the cause or etiology, meningitis is classified as either bacterial, viral, fungal, parasitic, or non-infectious meningitis. Now, onto the pathogenicity of meningitis. This is a process by which the infection occurs and the course it takes in the body. There is an initial colonization, then the pathogen escapes the host defense mechanism and reaches the blood-brain barrier through one of three major routes: replication and hematogenous spread through the bloodstream, which is the main route of viruses. Second, infection of the peripheral nerve followed by retrograde neuronal travel up the nerve to the central nervous system. Bacteria that use this are Naegleria fowleri via the first cranial nerve and the HSV2 virus. And third, direct contiguous spread through ears, nasopharynx, skull fractures, and congenital meningeal defects. The pathogens have to cross the blood-brain barrier, which is commonly done through the following mechanisms: A. Transcellular migration, where the microbes traverse to the human brain microvascular endothelial cells without disrupting intracellular tight junctions. B. Paracellular migration, where there is interbarrier cell penetration with or without tight junction disruption. And C. Trojan horse mechanism, in which transmigration of microbes across the blood-brain barrier occurs after ingestion by phagocytes. Patients with meningitis commonly present with the following clinical features: neck stiffness, photophobia, malaise, nausea, seizures, and altered mental states, this means confusion, delirium, or comatose state. Going more in depth on the various forms of infectious meningitis, we'll start with bacterial meningitis. Acute bacterial meningitis is a medical emergency in which the bacteria crosses the blood-brain barrier into the subarachnoid space where they multiply, releasing cytokines and causing an influx of neutrophils and pus formation, which would increase the permeability of the blood-brain barrier. There will thusly be an increased intracranial pressure from the pus in the subarachnoid space, cerebral edema from the increased permeability, and small vessel thrombosis. A fever greater than 38 degrees Celsius is not uncommon. Now, certain risk factors can hint at the etiology of meningitis. In immunocompromised individuals, the most likely cause is L. monocytogenes or Streptococcus pneumoniae. In those with CSF shunting, it is Staphylococcus epidermidis. For those with intracranial surgery recently, Staphylococcus aureus is the most likely cause. And for those with skull fracture, congenital meningeal defects, and contiguous spread from other sites, Streptococcus pneumonia is the most common cause. Others at risk of bacterial meningitis are those in crowded areas, the young below 5, the elderly above 60, IV drug users, HIV patients, alcoholics, sickle cell disease patients, liver cirrhosis patients, and those with ventriculoperitoneal shunts. Certain symptoms are also indicative of their cause, such as petechial rash, which indicates meningococcal meningitis and is caused by Neisseria meningitidis. Meningococcal meningitis is a severe life-threatening form of meningitis with a 50% fatality rate in untreated cases. It is transmitted by respiratory droplets through sneezing, coughing, or kissing. Even with immediate treatment, severe complications such as brain damage and hearing loss are common, and the best method of prevention is vaccination. Meningococcal meningitis often causes and occurs in concert with septic shock, a medical emergency. In such cases, there is a rapid escalation of symptoms as well as Waterhouse-Friderichsen syndrome, which is hemorrhage of the adrenal glands. For viral meningitis, this is a common community-acquired meningitis. It is often called aseptic meningitis as its cause is not apparent on initial examination, routine staining, or CSF testing. Viral meningitis is mostly self-limiting. The most common cause is enteroviruses, such as Coxsackie viruses, echovirus, or poliovirus family. These are especially common in children and in the summer months. HSV2, that being herpes simplex virus 2, mostly causes meningitis, while HSV1 is more associated with encephalitis. Fungal meningitis rarely occurs. It is commonest in steroid users, immunosuppressed people, chronic disease patients, HIV patients, very low birth rate babies, and those in high-risk areas. Prolonged antibiotic use are also a factor. Parasitic meningitis, on the other hand, is also called eosinophilic meningitis, and it is the rarest form of the 5 meningitis. Then finally, non-infectious meningitis. This is also called aseptic meningitis when the CSF cultures are negative. It can be caused by drugs, autoimmune disease, malignancies, and on rare occasions, vaccines. Symptoms are mild compared to infectious meningitis. Chronic meningitis is caused by tuberculosis, Cryptococcus neoformans, Behçet's disease, sarcoidosis, and syphilis, among other things. Typical features are a vague headache, anorexia, lassitude, and vomiting, with focal signs of diplopia and papillary edema, as well as seizures. Now, the clinical features of meningitis are irritability, poor feeding, and lethargy in both infants and the elderly, with high-pitched crying and bulging fontanelles present in infants alone. Now, the prevention is usually better than cure, so prophylaxis is always taken to avoid meningitis. Respiratory etiquette, good hand hygiene, prompt cleaning of skin injuries, prophylactic antifungals, safe sex practices, and avoiding exposure to rodents can all prevent meningitis. Chemoprophylaxis for those living with Neisseria meningitidis or H. influenza patients is highly recommended. For vaccinations, H. influenza can be given in infancy, and strep pneumonia and Neisseria meningitidis boosters are given every 5 years. For residents of non-endemic countries traveling to meningitis endemic countries, it's highly recommended to take chemoprophylaxis before your travels. Thank you for watching our video.